Hello everyone, today we will discuss endometriosis and fertility. We will go over its prevalence, how it affects fertility, diagnosis, management strategies including surgical and medical options, and how assisted reproductive technologies can be planned in these patients. Discussion is based on recent evidence and guidelines from the European Society of Human Reproduction and Embryology. Endometriosis is a common condition affecting about 10% of women of reproductive age. Among women with endometriosis, 30 to 50% experience infertility. On the other hand, 25 to 50% of infertile women have endometriosis, showing a strong association. Endometriomas, which are ovarian cysts resulting from endometriosis, are found in approximately 17 to 44% of women with endometriosis. They are significant because they can directly affect the ovarian reserve and the quality of eggs, contributing to infertility. Endometriomas can cause infertility through several mechanisms. First, they can reduce ovarian reserve. Surgical removal or the cyst itself can damage ovarian tissue, lowering both the number and quality of eggs. Second, endometriomas can distort the pelvic anatomy. Adhesions and cysts can block the fallopian tubes or make egg retrieval difficult. Third, the cyst creates an inflammatory environment around the ovary. Oxidative stress and cytokines are increased, which can reduce egg quality and fertilization potential. Understanding helps us plan appropriate management strategies. The diagnosis starts with a detailed history and pelvic examination. We assess pain, menstrual irregularities, and fertility issues. Imaging is crucial. Transvaginal ultrasound is the first-line tool to detect ovarian cysts and evaluate their characteristics. Resonance imaging is used for detailed anatomy, especially in deep endometriosis. Laparoscopy, although previously considered the gold standard, is now reserved for cases where the diagnosis is uncertain, when severe pain persists despite medical therapy, or when surgery is planned, which avoids unnecessary surgical procedures. When surgery is indicated, cystectomy, which is removal of the cyst wall, is preferred over simple drainage or coagulation because it reduces recurrence and preserves ovarian tissue. Indications for laparoscopy include severe pain not relieved by medical therapy, large cysts greater than 3, suspicion of malignancy, and situations where cysts interfere with egg retrieval for assisted reproductive technologies. The goal is to relieve symptoms, remove disease, and preserve as much ovarian reserve as possible. Medical therapy can be used before in vitro fertilization to improve outcomes. Monthly injections of gonadotropin-releasing hormone analogs for around 3 months can reduce cyst activity and inflammation. Progestins or aromatase inhibitors can be used as adjuncts. The aim is ovarian response during stimulation and reduce local inflammation, which can make egg retrieval easier. However, the evidence shows that medical therapy does not necessarily increase live birth rates, but it may help with surgical planning and comfort during in vitro fertilization. For women with endometriomas, assisted reproductive technologies play an important role. Intrauterine insemination can be considered for women with mild endometriosis who have otherwise normal ovarian function. In vitro fertilization is preferred for women with moderate to severe endometriosis or previous treatments. Pre-in vitro fertilization surgery should be considered only if there is pain, difficulty accessing eggs during retrieval, or suspicion of malignancy. Surgery should always be individualized to avoid unnecessary loss of ovarian reserve. Women with endometriomas may have a reduced ovarian reserve, so careful planning is needed for ovarian stimulation. Individualized protocols are essential to optimize the number of eggs retrieved. Close monitoring during stimulation allows adjustment of medication doses to prevent poor response. In selected cases, pretreatment with gonadotropin-releasing hormone analogs can help reduce local inflammation and improve egg retrieval. The key is balancing effective stimulation while preserving ovarian reserve. This table summarizes a practical approach. For mild endometriosis with infertility, intrauterine insemination may be appropriate. In moderate endometriosis with pain, surgery followed by in vitro fertilization is recommended. In severe endometriosis with bilateral fertilization can be done without prior surgery to avoid damaging ovarian reserve. For endometriomas larger than 3 cm that may interfere with egg retrieval, cystectomy before in vitro fertilization should be considered. Decisions should always be individualized based on patient's ovarian reserve and fertility goals. In summary, cystectomy is the preferred surgical approach for large endometriomas. In vitro fertilization is often required in moderate to severe endometriosis. Medical therapy and surgical interventions should be planned carefully to preserve ovarian reserve. A multidiscipline involving gynecologists, reproductive endocrinologists, and fertility specialists is essential to achieve the best outcomes for patients. This approach ensures that fertility is optimized while minimizing risks. Thank you for watching. If you found this video helpful, please like and subscribe for more educational content. If you want more videos on specific topics in obstetrics and gynecology, reproductive medicine and surgery, embryology or gynae endoscopy or any chapter in any book, leave your suggestions in the comments. Remember, stay curious, keep learning, and take care. Thank you.